Almost all of the common drugs that are used have different effects in different people. And on average, most of the time, there's a large proportion of people who are helped by FDA-approved drugs and get the desired effect. But unfortunately, there's often a large number of people who are having little or no effect of the drug, little or no positive effect, but maybe having side effects. And then there's often some unfortunate percentage of people that are actually being harmed by a drug. And this is true of just across all the drugs that are FDA approved. Different drugs have different degrees of this. But let's take some common examples. The number one drug prescribed in America is codeine. Codeine is part of Tylenol number 3, is part of a lot of different drugs. But codeine doesn't work in 30% of the US population because 30% of people are not able to transform codeine into the active drug, which is actually morphine in the patient's body. So if you don't convert codeine to morphine, you get zero pain relief. All you get is side effects from the codeine. So 1/3 of the time the physicians are writing the prescriptions without knowing the genetics of their patient, they're taking that gamble that maybe they're right, maybe the patient's going to convert the drug, but 1/3 of the time they don't. Now it's possible to test that. And before you write the prescription, you could use the device under development to just look and see, very simply, whether or not they are a codeine metabolizer or not. And that gets very exciting to think about using that every time you're writing a prescription. Almost all the common drugs have genetic variants that affect whether you metabolize the drug too quickly, too slowly, whether you convert it to the active drug, whether you don't convert it to the active drug. And so all of those things become very important in caring for patients. And what we can do is go from trial and error prescribing to more scientifically based prescribing, where we know that this patient has a risk and we should avoid this drug in that patient. Or we know that a lower dose of the drug is likely to be effective in this patient, and we don't overdose the patient, and we also don't overspend on the medication. This turns out to be huge in some populations. For instance, the elderly population, it's estimated that people over 65 in our country on average take about 8 prescription drugs. And people over 75 on average take about 15 prescription drugs. And these are drugs that have never been tested in these combinations. And on average, there's 2 or 3 of these drugs that could be dropped without harming the patient's care, where those drugs are either not doing anything or where they may actually be doing something harmful for that elderly patient, making them more prone to falls, making them more prone to depression, making them more prone to being readmitted for whatever their primary condition may be, whether it's heart disease or Alzheimer's disease or other kinds of things that they're being treated for. So it becomes very exciting to, with simple testing, be able to avoid some of those drugs, to be able to avoid some of those costs, to be able to avoid some of those hospital readmissions, some of those falls, some of those things that we think about, the hardships of being elderly. So much of that is actually the burden of the overprescriptions that are occurring in the elderly. And if simple diagnostic devices can help reduce that, it not only saves healthcare costs, it really changes the perspective of how the patient's doing.